Last Monday of March, and here you are with Pospo and BRAINCAST for Monster Learning. And whether you believe it or not, we are officially 1 year after our first lockdown. No need to celebrate this kind of anniversaries. It's like celebrating the anniversary of a failed marriage. You wouldn't celebrate that, would you? So let's hope it's the last time we have to mention lockdown in our lives, and we won't be here in March 2022 commemorating the second year in lockdown. We do need to celebrate, though, the birth of a really important person, because without this person, there wouldn't be BRAINCAST, because basically there wouldn't be me. Happy birthday, Mom. I love you.
Aww.
Last week, we welcomed Prof. James Nasbury, a professor of sociology up in Manchester, and together we explored the extremely complex world of racial inequalities in mental health. A fascinating video of which you can find on YouTube. Not a big fan of videos? No worries, try podcast on Spotify. This week, though, we leave the warm, tropical climate of Manchester and fly across the ocean to the horrible weather of Florida. I mean, who likes long, sandy beaches and clear ocean waters? I know. But we're not here to talk about holidays, although my guest is a fan of scuba diving indeed. But she's also a mega fan of science and the thing that brings us all together every Monday, the brain. She's an associate professor at Mayo Clinic in Jacksonville, Florida, and has dedicated most of her research, and we're talking nearly 200 papers, investigating the individuality of Alzheimer's disease. She leads the Translational Neuropathology Laboratory that, among other things, aspires to uncover potential biomarkers for Alzheimer's and other dementias. She also loves records, but if we start talking about that, I doubt we're going to talk about anything else. So let's focus on the brain. BRAINCAST people, this is Dr. Melissa Murray. Melissa, welcome to BRAINCAST.
Hello, thank you very much for welcoming. It's exciting to be here.
Melissa, since you love scuba diving, let's dive in straight away. So who was Aloysius and what do we owe to him?
I think we actually owe an incredible amount when you allow yourself that time to observe differences and changes, especially as it's pertinent to even a single patient. As we can see with Alois Alzheimer, it can change the world. And quite frankly, that's what he's done. He's really opened up so many avenues for us to be able to understand the devastation that occurs.
Amazing. I mean, in one of the most highly cited papers in Alzheimer's research, Ron Brookmeyer wrote back in 2006 that we face a looming global epidemic and that by 2050, 1 in 85 persons worldwide will be living with the disease. And up-to-date statistics from the Alzheimer's Disease International, they don't look that great. So is it that bad?
It really is, sadly, unfortunately, that bad. There's been some progress that I think we'll talk about in a little bit about lifestyle interventions, but at this point, as you mentioned, the Alzheimer's Association has a number of really startling statistics that 1 in 3 seniors will actually die with Alzheimer's or another dementia. And the cost alone, not just on the emotional toll, but $355 billion, if you will, that has been spent on the cost or the care of different individuals. And whether that's government or being taken on by the family is really quite striking.
Now, before we go all out science, can you please give us a 45-second overview of the basic pathology one typically finds in Alzheimer's so that people not familiar with the disease can familiarize themselves with the basics? Your time starts now.
Let's start. So, basics, we have 2 different types of proteins, and that's what makes Alzheimer's one of the more difficult diseases to study. One aspect of the protein accumulates inside of the brain cell, and those form neurofibrillary tangles. They actually will start in the brainstem and then spread upward. Interestingly, the other protein that's abnormally accumulated occurs outside of the brain cell, and it actually begins in the outer part of the cortices and then descends down. So although 2 partners in crime, they somehow intersect to wreak their devastation.
Amazing, and right on time. And while everyone, Melissa, uses Alzheimer's as a, if you like, one-size-fits-all diagnosis, it seems that this is far from true. In fact, it was around 10 years ago when, in an amazing paper at Lancet Neurology, you showed that 1 in 4 people with Alzheimer's do not show the typical distribution of the tangles that you mentioned earlier in the brain. So what did you find, and why is this important?
So that is one of the more interesting aspects. So we read textbooks. This is what we learn about the disorder. This is what we live by. And of course, we always keep an open mind. And when you look under the microscope, what's so intriguing about a subset of individuals is that they certainly didn't read the textbook, if you will. So I mentioned that the pathology will begin down here and ascend. So actually the tangle pathology really initiates near and around memory structures. But intriguingly, there's a whole subset of individuals where the brunt of the pathology is in the outer part of the cortices, which of course then leads to focal cortical presentation, so non-memory disorders, which really gives some of the clinicians some difficulty in trying to think about what may be underlying the clinical presentation. And then oppositely, so we call those hippocampal sparing. Oppositely, we have a limbic predominant form where the devastation actually remains relatively confined to the limbic structures. There'll be some outer cortical involvement, but that sort of seesaw pattern or imbalance doesn't actually just extend to the pathology. Intriguingly, we see sex differences, we see differences with regard to genetics, we even see differences with regard to age. And that's one of the more striking aspects. Our hippocampal sparing cases are often much younger and haven't even gotten to live out the fulfillment of the beauties of the golden eras.
Wow. And of course, that leads us to one of your main research interests, atypical Alzheimer's. I know it's going to be impossible to summarize your 2021 Lancet Neurology paper titled New Insights into Atypical Alzheimer's, but I think it is worth a try. So can you please tell us, what are the main differences, if you like, between typical and atypical Alzheimer's, and if there are any implications that you can think of in treatment?
Yeah, so the main aspects, if we wanted to boil it down, would be memory versus non-memory. If we're thinking about atypical, we think about our non-amnestic clinical presentation. So those individuals may have behavioral disturbances, visual spatial. Actually, some of your neighbors are one of the key stakeholders in posterior cortical atrophy, which is one of the most common non-amnestic syndromes. But we can also have issues with regard to apraxia. So we have phantom limb and we think about corticobasal syndrome. It's not necessarily what we think about with Alzheimer's, but 50% of those cases may actually have underlying Alzheimer's pathology. And while therapeutic interventions and implications are still being thought about, we have some early evidence to suggest that the hippocampal sparing cases may actually greatly benefit from cholinergic treatment, anticholinergic treatment, so that we can actually hopefully intervene earlier, but that is still well underway and the results are not quite mature yet.
Okay. That's really interesting. And I mean, in a fairly recent revision of the original, if you like, staging system, the locus, and you know that I hate this word because I cannot really pronounce it. Yes, so the LC, we're going to call it, is suggested to be one of the earliest brain regions to be affected in Alzheimer's. And a quick neuroanatomy refresher: the LC is a collection of noradrenergic neurons in the pons near the floor of the fourth ventricle. In a 2020 paper for ACTA, that's definitely not for the faint-hearted, you talk about the importance of that finding and its implications in therapeutic interventions. So tell me a bit more about this area of the brain.
I'd be happy to. This was actually a labor of love by one of my fellows who turned the pandemic into lemonade. So she may have been served lemon, but Billy Matchett, what she did is really looked at the entirety of the bulk of information that we understand on locus coeruleus involvement in Alzheimer's disease. And the Brocs have really helped us to understand the topographic distribution, and more recently, really giving us an understanding that this tiny blue spot, the locus coeruleus, may be the earliest area that we see the tangle pathology of Alzheimer's. And what's so striking about it is we talked about our atypicals and we started to talk about the age differences. What we see is potentially different aspects of involvement, perhaps even greater aspects of involvement in the locus coeruleus in our younger onset Alzheimer's disease individuals. And while that controls the noradrenergic function, those deficits may be playing a role in some of these inflammation integrations that we've been seeing. So the overactivation of the inflammatory system perhaps could actually be held off by some of the therapeutic interventions targeting that tiny blue spot.
Wow. So now the main question, if you like, that has been burdening scientists and clinicians alike for many years, and I have to say not only in the field of dementia, is why some people develop dementia while others don't. And it seems that this is a question that you tried answering in a few of your papers. In a JAMA Neurology paper, you talked about selected vulnerability, while in another one, you studied the brains of people who were able to tolerate, vast amounts of plaques and tangles, without experiencing dementia while still alive, suggesting that there is some form of resilience, if you like. So tell me more about vulnerability and resilience in dementia.
It's such a fascinating topic, and especially in the context of neurodegeneration, where one of the great mysteries is why. Why are certain areas of the brain so vulnerable to different parts of the disease? And so we can think of the individual. Some people may not accumulate the pathology sufficiently to actually present, or intriguingly, could some people accumulate sufficient amounts of pathology but actually not have that level of devastation? We think about cognitive reserve, so individuals who really are trying to keep active, up to date on the literature that's outside of what they necessarily study, or once we get to retirement, really keeping that mind engaged. And can that be one of the areas that allows us that resilience? Now, if we go inside the brain, what's even more interesting is why some parts of the brain remain resilient when they shouldn't in the context of a disease. So nucleus basalis of Meinert, we were just talking about the JAMA Neurology paper. This is an area we know to be devastated. It's our cholinergic hub. But in the context of Alzheimer's disease, there's even a spectrum. Some have a greatly affected nucleus basalis of Meinert, and some do not. That actually ties back into those Alzheimer's disease subtypes we talked about earlier. And I think that it's really trying to tell us a message. We have to listen to the biology, that there is a clue there that there's actual internal mechanisms that we need to identify where that resilience and that selective vulnerability may play a role.
Amazing. And now, just hearing you talk about that, it's really interesting because, we were looking into using deep brain stimulation, targeting, NBM, the nucleus basalis Maynard. And, you're saying that there is actually, a range of people that are vulnerable or resilient. This may also be a reason why the results of the deep brain stimulation targeting NBM are so heterogeneous. That's so interesting. So, Elisa, there have been a few massive, I have to say, multi-domain trials and a great review by Mia Kipipelto in Lancet Neurology, summarizing how lifestyle interventions can prevent cognitive impairment, dementia, and Alzheimer's disease. So how do you think, lifestyle interventions, how can these findings be blended, if you like, with neuroscience like your studies?
Yeah, no, it's such a good question. And I think the lifestyle intervention, there's still so much we don't know. And to use a non-clinical term, there's magic substances that just keep us going because our biology is so impressive. And honestly, it may really be that intersection within the context of Alzheimer's disease, especially that intersection with vascular. So if we can keep our vascular health up and going for those walks every day, or maybe saving McDonald's for once a year, not necessarily to target McDonald's, but that concept, going for the healthier options. We don't know the full extent of why, but we know that it's working. And so those lifestyle interventions, continuing as much as you can to keep up that health, maybe it just allows your body to fight it more. And that's what we need to do, is give our bodies a chance to do what they do best.
And since we touched on treatment, I could easily name the many failures of modern psychopharmacology in general, not just in dementia, but it seems that dementia is a field that we are getting particularly, we're not getting that luck, if you like, although I don't think it's a matter of luck. And even medication with lots of hype, like, the recently published study of donanemab in New England Journal of Medicine, only delivered modest improvements. And I'm being pretty generous there. So where should we focus our pharmacological approaches, you think?
So I think where the future is going to hold is perhaps not targeting necessarily the pathology that we're seeing under the microscope. We need to think about what may be enabling that pathology. And so we talked about partners in crime when it comes to tangle pathology and amyloid, but what might actually be encouraging that pathology to happen? So could we find almost a nearest neighbor approach where Is there a protein that enables this system to go awry? Because perhaps our bodies are just fighting the disorder, but then they get out of whack. So can we get in there early? And that's where the treatments have been pushing back to earlier and earlier in the disease course, and especially with the integration of biomarkers. We really need to know that the individuals we're targeting truly have the disorder that we're targeting.
Okay, enough with molecules, and let's get a bit political, Melissa, because whether we like it or not, everything is political. So according to Alzheimer's Disease International, 60% of people with dementia live in low and middle income countries. But by 2050, this will rise to 71%. And I doubt this is only explained by genetics. So what do you think?
Yeah, and even the genetic contribution, if we think about frank mutations, so those really striking breaks in the DNA or the mutations that enable a different amount of protein, 95% of Alzheimer's disease in the current modern era is what we think about with the sporadic form. So there has to be contributors. What are those contributors? Part of the difficulty, so I grew up in a humble background, is access to different types of food. The more convenient the food is, probably the higher the sodium is, or the higher the carbohydrate level. And so what can we be doing about our health? Are we too busy with work trying to make ends meet to go for that walk? And could we potentially even integrate a walk in with our family members? The difficulty is time changes when you're living from paycheck to paycheck. And so can we do things that may help to improve this? But the difficulties are so fast that we just don't even have a good handle on it, unfortunately.
And I mean, on a roughly similar note, a 2019 paper showed that racial differences were present in some biomarkers of Alzheimer's, as African American individuals have lower levels of CSF T-tau and p-tau 181 compared with white individuals. But even if we were to think about treatment, in a trial of solazunemab published at the prestigious New England Journal of Medicine, only 33 people out of 2,100, I can't remember, 33 out of 2,000 participants were only African American. So what do you think are the consequences of this?
We need to understand the disorder across all individuals who it affects. I mean, so taking Alzheimer's disease does not know what color your skin, and it does not know how much money you make. Unfortunately, it is not targeted in a sense that we could then understand it in a better way. And so we really need to understand how much pathology matters for an individual. Does this matter depending on male versus female? Does this matter depending upon your ethno-racial background? And one of the coolest programs that I've learned about, so John Lucas, who's with me at Mayo Clinic in Jacksonville, Florida, he took some time and he visited Washington University, who's made great strides in this area. And he developed what he calls the ambassador program. And so he actually works with community leaders in the African American community to ensure that the understanding of the participation or the understanding of where the true altruism comes from is being communicated by people who will interact with others and who others want to listen to. Because sometimes if you don't recognize the person that's giving you the information, maybe they aren't the same sex or they aren't the same color, you may not feel as comfortable. And so really engaging with the community and ensuring that the messages are translated in a culturally sensitive manner, I think will be the game changer. And that's what we need to have more of at every institution, because I know all of my colleagues are desperate and really want to ensure cultural diversity and ethno-racial diversity. And there's a mismatch. And so we need more funding in this area, and we need a lot of individuals out there willing to take the charge and bring the information out to the public.
Now, it's a well-known fact that, ethnic minority groups are being hit harder by mental health issues, including severe mental illness. Now, Melissa, psychiatrists have even more reasons to be interested in dementia and its links with severe mental illness. In a 2021 JAMA Psychiatry paper, so Scott Troop found that people with schizophrenia compared those without a severe mental illness received dementia diagnosis at younger ages. Notably, the prevalence of diagnosed dementia among people with schizophrenia at 66 years of age was similar to the prevalence of diagnosed dementia at 88 years of age for the group without schizophrenia. So what do you think is happening there?
So intriguing. I don't know if I'm the right person to speak on that. Is it okay if I pass? Because I don't want to misspeak on the issue. Yeah, I don't know. I know that for us, especially in the context of Alzheimer's disease, the neuropsychiatric disturbances and the actual behavioral changes, or even depression as an antecedent to the disorder, there's a huge issue with making sure that our neuropsychiatrists and our neurologists are really effectively communicating together. You know, is this a lifelong disorder that we need to be thinking about that's now going to be in the context of a degenerating disorder, or is this a harbinger? And we really need to make sure to take care of those individuals at different ages, and we need to be thinking about what do we see in an individual who all of a sudden is presenting in their 40s and 50s with a disorder that is more likely to have presented at 20s and 30s. And so I think more effective communication, although my mom's a psychotherapist, so I think effective communication runs in my blood.
And Melissa, I mean, you mentioned a bit the behavioral aspects, and the truth is that, you know, although the first thing that springs to mind when someone mentions Alzheimer's is memory, one of the most distressing symptoms both for the patient and the carers are the behavioral and psychological symptoms of dementia. And, you know, up to some extent, this can be understood as, if you like, ineffective attempts of the patient to cope with environmental or physiological stress factors. But that's certainly not the whole story. So I know it's a bit of a tricky question, but has your research uncovered any links we should know about with the behavioral aspects of dementia?
So not my particular research, but this is definitely an active area. There are interesting, we talked about our non-memory forms, our atypical forms, and there are interesting presentations of individuals with behavioral aspects or more of a dysexecutive function. So they have a lack of planning capabilities. And while Alzheimer's disease was not traditionally thought of first with those, we are more and more comfortable with the fact that actually tangle pathology is developing perhaps in a greater abundance in the frontal region. And we really need to be thinking about, because we might have some targeted treatment that could intervene, and even if it slows it down. I mean, if I had had 6 extra months with grandma recognizing me, that would have been worth it. And so there is an important intersection that is still really being thought about.
So Melissa, let's catch then a glimpse of the future. So take me through the clinical journey of a patient with dementia in 2221, so in 200 years.
I love it. Well, I mean, Star Trek comes to mind because you think about like targeted treatment. I think in 200 years, if we haven't prevented dementia altogether, so we'll pretend in this aspect, I think that our multimodal attempts at imaging will have completely intersected, so that the information that would be pulled out would be such a 3-dimensional level that would enable us to understand the interactions. Because unfortunately, what we do now is single, and we try to compare it with our mind. I mean, you could do it with technology, but the technology would be so advanced that you'd have it all together. And the idea would be if we got to it early. So guess what? 30 minutes a day. So in my mind, or my hope would be that if we had to deal with it, we would have a very specific information that if the patient followed, we could even tell them down to the day how much this would delay. And if you gave a patient that much power, perhaps there could be a lot of change, and especially with the caregivers, for them to understand, because I think we think about our patients, we think about our clinicians, and we really need to think about our caregivers and the devastation that this wreaks on them. And so if that empowered them to have that information, I think it would be a whole new world.
A whole new world. So Melissa, let's end with the man we started with, Aloysius Alzheimer. My dear friend Wikipedia says that he was a German psychiatrist, a neuropathologist, and a colleague of Emil Kraepelin, another psychiatrist, by the way. So Alzheimer is credited with identifying the first published case of presenile dementia, which Kraepelin would later identify as Alzheimer's disease. So, two psychiatrists discovered, if you like, Alzheimer's dementia, yet neurologists stole it from us. So how did we let this happen?
Well, I think y'all were just sleeping on the job. No, I'm just joking. So I think that it's an incredible, and once again, it goes into that observation of the behavioral differences, which he found strikingly different than what he had observed. And it was the perfect intersection of technology at the time where some of the stains became a reality. And so really, he changed the whole world. But when, and especially it evolved in the 50s and 60s, when the concept of dementia really started to continue to evolve out of there, the field of neurology wholeheartedly embraced it. And when we think about functional differences versus degenerative differences, it continued, and it has sprung into biomarkers and changes and therapeutics. And so but I think there needs to be that embracing again in that intersection with neuropsychiatry and neurology, especially in our younger individuals who will often have atypical symptoms. And so we don't know how much we would have classified Auguste as young onset, given she was less than 65, but that age kind of will have changed over the years. And so no, I think, thank goodness he found it, and I'm glad that people continue the charge, and let's hope that we continue to work together toward ending this devastating disease.
Yeah. Fantastic. BRAINCAST people, this is Dr. Melissa Murray. Unbelievable work on Alzheimer's from a tireless brain. Thank you so much, Melissa, and good luck going back to Florida's horrible weather. As for us, well, we stay here under the, I have to say, not that bad skies of London today. Next week, you're all dismissed. You can do whatever you wish. It's Easter Monday, but make sure you make a note for April 12th as we're traveling to beautiful Switzerland, where we meet one of the most prominent figures in the world of eating disorders, Professor Nadia Micali. Until then, Pospo and BRAINCAST for Monster Learning. Over and out.
Bye-bye.